So it's a great pleasure to be here and to share with you what we have got with the evaluation that by now is still in place with the NGS genotyping system by Vela. So I need to have some disclosure made public. And I need also to specify that we are not a reference center. We are just a large, probably one of the largest in Italy, clinical virology laboratory. So our approach is really practical. We will not provide you with any detail like Christophe made just before me. And since we are running quite low in time, I will try to skip over all these introductions that are not so important. I would just like to show why we are interested in HCV genotyping, because we are a country in dark blue. And so we have a high prevalence of infection with a very mixed, how it works? With a very mixed situation. So our situation is much worse than other countries. So that's why we need to, and also maybe because of this, the patient interest in the treatment is really huge. So we need to give them some information as detailed as possible. Well, this is well known, but I wanted just to let you know that we are working on this system because we are working with LIPA. And of course, as just got the information, the system for genotyping by Vela is working on the other gene. This is a very well-known rate of genetic variability of HCV, so I need to skip over. This is the Sanger system, that is the reference, but this is the system that we use for about 1,000 genotyping here in my laboratory. Oh. Okay. Why we are interested in having something more, or something new, or something more informative. These are the data that the UK NICAS EQA provided to all the participants in 2013. So they are not really updated, but they clearly show that the most used in this circuit is the INOLIPA version 2.0 test. And of course, this is a very good test, but there's some drawback that needs to be overcome in order to adapt to increase the clinical impact of the data that we provide to the clinical side of the story. And that's why we decided to try this system. Okay, let's skip over this because it's very well known. This is a system that provides you a lot of information. So for me, as a virologist that has a very strong background in arboviral infection, I'm not an expert in HCV. My background is in mosquito-transmitted infection. But having this kind of information made me quite confident that we can trust the information we get, because you get a lot of information that are not just the software that says it's positive or it's negative, it's 1A or 1B. So you can have an analysis quite informative, so you can get over the data that the software provides you, because you get information about the quality of the run and about the total number of reads you get. So that's really informative. It's not a matter of faith, it's a matter of having this information available. So we tried with the routine comparison of, this is just the very first batch of sample that we analyzed. And I would like to draw your attention to some differences that are indeed very important to us, very interesting for the comparative evaluation of these two methods. So this graph shows the result that we got with these 207 samples. These are just routine samples, getting into the laboratory with the request, with the prescription, having a genotype. So there is no selection, there is no particular issue behind this sample. This is just a routine sample. And as expected, you see here that the most prevalent genotype are 1A or 1B. And followed by 3, oh no, followed by, yes, 3. And what is really interesting to us is that we got some genotypes that are not solved. So the enolipa says 2A or 2C, or the enolipa says 4A, C, or D. And in this case of mixed infection, the result was 1A plus something in E4. When you go back and you see the result that we got with Vela, of course there is no differences, major differences, and I'll show you some detail about the results just in a few seconds. So the overall evaluation is not so different. So what you get with the enolipa is the same you get by using Vela in routine. The interesting thing is that there are no more unsolved genotypes. So you get precise information about the genotype that are infected. And these are the details. Could be quite complicated, but I will try to make this long story very simple. So in this direction, you see the results we get by using the LIPA, and in this direction, there are the results we got by using the NGS Vela genotyping system. So in 62 cases, 1A was confirmed. In 2 cases, the unresolved 1A was 1B and 1G. 1B was confirmed in 46 cases. The issue having a 2 not subgenotyped was 2C in 7 cases, as 2, 1, C and D in 1 cases, and 2K in another one. We have only 1 cases of not confirmed result. As you see here, the information we got from LIPA was 2A or 2C, and Vela says 3A. 3A was confirmed very nicely here, and these 2 mixed infection, in this case, for A, C, or D were just 4D, and the most complicated sample, 1A plus something in 4, was 1A plus 4D. So that clearly showed that the power of detection, the power of detail that you can get by using the result is really superior to the result you get by the standard LIPA genotyping system. Of course, you can get information about the detail, well, it's not clear to read, but sorry, but you can get detailed information about the proportion of the mutation that you get by genotyping. I don't want, oh, no, sorry. And it's also nice that that's just a case that is still under investigation, as it is the case of discrepant result in between the LIPA that was saying 2 and the 3A detected by the NGS by Vela. It was really interesting to us, and this is still under investigation because we don't have so much clinical information. It's just a result that comes out some day before I left. In this case, we got a 1A genotype showing this kind of mutation in the NS5 with a very low detection of Q30R that was detected by the system. And after 12 weeks of therapy, the same patient was not showing an SVR, still the same viral load. So the clinician said, maybe we have some problem, and the problem was that probably the selection of Q30R was causing the failure in therapy, and the Vela system was capable to detect 99.6% of this mutation in the sample, not showing any more relevant mutation of M28P and M28T. So, in conclusion, we had only 1 discrepant result over 207 that we tested in respect of what we call the reference method, that is a standard method in our laboratory. Another important conclusion, as I told you before, we are a routine clinical virology laboratory. We have a huge routine. We do more than 60,000 viral tests per year in my laboratory. So it was really important to understand if the Vela system is feasible, and in fact it is. So you need just to have a couple of well-trained people, and you can trust this test as a routine test that you can perform daily or weekly or whatever you want. Okay, no. May I get back to, okay. So another potential conclusion is that the Vela NGS site provided a clear-cut identification of the HCV genotype, much more than the unresolved cases, with a high power to detect mixed infection. That's an additional feature that we like it very much. And also that the therapy selection mutation are clearly identifiable. So I think that I'm not a clinician. I'm a doctor working in a laboratory since the last 30 years, so I cannot say anything about the true clinical impact of this test for people that is taking care of the HCV patient. But under the laboratory point of view, I can say that it's a very interesting test that could be evaluated. And I would like to thank my people and to say that we could love LGS.